So welcome everyone. We have the pleasure today of having a Dr. Öner from Turkey who will talk about the stem cells therapy in degenerative retina and optic nerve diseases. Dr. Öner, thank you very much for accepting our invitation, and please go ahead.
Okay. Hi, everyone. I'm happy to be here, and thank you for the invitation to Dr. Atello. Today, our topic is stem cell therapy in degenerative retinal and optic nerve diseases. We will talk about the present applications, and we will talk about the future applications. Now, my presentation includes some headlines. These are the headlines. I will talk about our health group in Turkey. I will explain GMP guidelines. I will do the definition of stem cell, and I will shortly explain the delivery ways of stem cells to the eye. And mostly I will share my experiences with you. Then I'm going on. Yeah, first I want to introduce you my facility. I'm working with Acıbadem Health Group. This is the biggest health group in Turkey. It has got 22 hospitals. 13 of them are in Turkey and 9 of them are in Europe. It has got a university, a private university, and this facility has a stem cell laboratory in it. And this is the genius guy who is the head of the laboratory, and he is working on cell therapies, cellular therapies, and gene technologies. This laboratory has some products like hematopoietic stem cell products, produce immunotherapy products, and they are working on tissue engineering products, like they can produce like artificial ears or artificial trachea. And they are mostly working on stem cell therapies. Speaking of stem cell, I need to define it. Actually, I'm calling stem cell the baby cell because it can be transformed in different kinds of mature cells. The stem cells have high proliferative capacity, and they have great potential to differentiate into different kinds of mature cells, and they can help to repair tissue or restore function. These are the main types of stem cells. The first one is embryonic stem cells. The second one is adult stem cells. Embryonic stem cells are not allowed in our country. They are forbidden by the Ministry of Health. So we cannot use them in clinical trials, or we cannot use them in experimental studies. So in Turkey, we can only use mesenchymal stem cells, and you can produce this kind of stem cells from adipose tissue, from bone marrow, or umbilical cord, or dental pulp. You can take different sources, and you can produce them in the laboratory. How do they act? These are the mechanisms of action. First, cell replacement. If you put stem cells in a tissue, they can replace unhealthy tissue cells. Embryonic stem cells usually act like this way, but we cannot use them in our country. The second mechanism is nutritional support. These stem cells can secrete some growth factors, some chemokines, some angiogenic factors, neurotrophic factors, so they can help the surrounding cells to survive. They do nutritional support for the environment. The other mechanisms are anti-apoptosis and immunomodulation. Mesenchymal stem cells usually work by this way, nutritional support. These are some of the growth factors that they are secreting. Mostly they are secreting angiogenic growth factors and neurotrophic growth factors. I need to say a few words about GMP. GMP means good manufacturing practice. This is a guideline for the laboratories, stem cell laboratories. These guidelines include guidelines about equipments, staff training, the operational processes of stem cell production, and the documentation system. These guidelines assure that these stem cells are in the same quality. They are pure, they are alive. So these guidelines are important for a laboratory. In Turkey, we have got 6 laboratories that have GMP guidelines, GMP standards. So they are controlled. They are controlled by the system, the government, the Health Ministry of Health. Now we are using stem cell implantation in degenerative diseases like retinal diseases and optic nerve diseases. Most of our patients are RP patients, retinitis pigmentosa patients, but we have got patients with dry AMD, Stargardt's disease, and optic nerve diseases. I will show you some examples. Stem cell in the eye has some advantages because the eye is small, so the amount of stem cells that you use is small, and the cost is low depending on the amount of stem cells. And you can use different surgical approaches to do the implantation, and you can monitor these cells or the effect of therapy with different kind of devices. If you are doing an experiment, you can use the fellow eye as a control. And the eye is, as you know, immune privileged, so you do not need immunosuppressive treatment during the follow-up period. These are the stem cells that are used for ophthalmological diseases, embryonic stem cells, induced pluripotent stem cells. We do not use them in Turkey, but there are different kind of experimental studies in Japan. Mostly we are using mesenchymal stem cells. And these are the surgical approaches for stem cell implantation. As you see, there are a lot of ways that you can use during the implantation process. You can use it intravitreally. You can do vitrectomy and implant it by subretinal way. You can use a suprachoroidal way. You can do retrobulbar injection or subtenance injection, or you can use intravenous injection of stem cells. This is one of the first studies that use stem cells. This study is called Reticence Study. They used intravitreal injection, and they used patients' own bone marrow-derived stem cells. This is called autologous way of implantation. And they reported a visual acuity improvement during the first year, but the improvement turned back. And this is another study which used autologous bone marrow-derived mesenchymal stem cells. They implanted these kind of stem cells in 3 patients, but they reported complication in 1 patient. The patient had severe fibrous tissue proliferation in the eye, and the patient had tractional retinal detachment, and the eye lost vision at the end of the follow-up period. The second way is subretinal implantation. You can use this way, and you can use stem cells in a suspension, in a liquid, or you can use them as a sheet, which is produced by tissue engineering. This is the first study that used embryonic stem cell derived retinal pigment epithelium cells, and this patient was followed up for 4 years, and as you see, there was an improvement in visual acuity, and this improvement lasts for 4 years. And the untreated eye, the fellow eye, had a decrease in visual acuity. There are some disadvantages of subretinal implantation. I had some experiences about that. I will tell it later. You cannot control the blood while injecting the stem cells to the subretinal area. And the stem cells may reflux to the vitreous cavity, and these reflux cells may cause some side effects like epiretinal membranes or retinal traction or retinal detachment. So you need to be careful while doing subretinal implantation. This is an injector which is developed for subretinal RP sheath injection. This is the tissue engineered product of RPE, as you see. And this is a patient from literature which received subretinal RPE sheath implantation. And the implantation survived during the follow-up period. The third way is suprachoroidal way. Actually, I'm a big fan of this way. I'm using stem cells by this way, and I will show you the technique later. You can do this suprachoroidal implantation by a cannula. You can cut the sclera and insert the cannula there. Or you can use another technique, which is called Limoli retinal restoration technique. I'm using this technique in my application of stem cells. Suprachoroidal way is safer than vitrectomy or intravitreal injection. We had no serious complications during this kind of therapy. This is the first publication of Limoli with this technique. He used he used stem cells in dry AMD patients, and he reported that nearly half of the patients had visual acuity improvement. And he had some publications in retinitis pigmentosa patients and glaucomatous optic neuropathy patients. And the last way is subtenance or retrobulbar injection. And you can combine this kind of injections with intravenous injections. There's a big study group which is called SCOTS, Stem Cell Ophthalmology Treatment Study Group in Florida. They are using the combination of these techniques together. And they had some publications in optic neuropathy patients and retinitis pigmentosa patients. And from now on, I will share you my experiences about this therapy. I have been working on stem cell therapies for nearly 10 years, and we had a facility in a university, and after the facility is established, I decided to work on this topic, and I'm now a PhD student in the facility. First, we started with subretinal injection, subretinal implantation way, and I will show you a small video. This is a routine subretinal injection. You can do it with a 41 cannula, subretinal cannula. We injected stem cells, adipose tissue-derived stem cells, by this way in 14 patients. They were advanced RP patients, and their visual acuity was very low. Some of our patients did well, and they had some visual acuity improvement, but some had some complications. This is one of the best patients. We followed him for 6 years, and he experienced a visual acuity improvement, and it lasted for 6 years. But we had some complications by this technique. One patient had choroidal neovascular membrane. As you see here, there's a membrane and hemorrhage. And some of the patients had a retinal membrane formation. And we had to repeat the vitrectomy and for the retinal membrane clearance. So I decided to find another way to do the stem cell applications. And then I met this Limoli guy, his first publication, and I contacted him, and I learned the details of the surgery. And in our phase 2 study, we used suprachoroidal implantation technique and in 20 patients. And in this phase 2 study, we again used adipose tissue-derived mesenchymal stem cells. This was in 2017. And then the results were pretty good. So we designed the phase 3 study. And in phase 3 study, we changed the source of the stem cells, and we used umbilical cord derived mesenchymal stem cells. And this phase 3 study was designed in 2019. And after the publication of this phase 3 study, we applied to the government, we applied to the Ministry of Health, and we had approval for other implantations. And we have an experience for more than 500 patients. We have some children in this group, and with this technique, the results are pretty good. I will show you this technique briefly. This is an extraocular technique, so there is no intraocular complication. You deviate the eye to the superior area, and you choose a temporal, inferior temporal quadrant. You dissect the conjunctiva, and you cut the conjunctiva. This is the bare sclera, and you create a flap, scleral flap, that you can see the color of the choroid from that flap. It's a simple technique, not a difficult one. If you are familiar to this kind of surgeries, you can do it easily. And you are creating a flap to the equatorial area. After creating that scleral flap, you dissect the fat tissue from the inferior oblique muscle, above the inferior oblique muscle. This will be the bed for stem cells, and then you suture this fat tissue under the scleral area over it. Now we are injecting stem cells to the fat, through the fat tissue, in the fat tissue, and then you close the conjunctiva. This is the technique. It takes nearly 10 minutes to do it. And now we are using this technique in retinitis pigmentosa patients, dry type AMD patients, Stargardt disease, and optic atrophy patients. We have no serious ocular complications, no systemic complications. And in overall, we have a 60% of improvement in visual acuity. 60% of the patients experience visual acuity improvement. And in 30%, we have stabilization. In 10%, you cannot achieve any success. So the disease goes on, and the patient has decrease in visual acuity. The results vary depending on the disease type and severity. So the most successful results are in dry type AMD patients, and the least successful results are in optic atrophy patients. These are the publications from our second study, phase 2 study, and we followed up the patients for at least 1 year. This is an example for one patient which had AMD. The upper figures are from the treated eye. These are visual field figures, and the lower figures are from the untreated eye, the fellow eye. As you see, there's a big scotoma here from the dry type AMD disease, and the scotoma decreased after the treatment, like here. This is the untreated eye, and in the untreated eye, during the follow-up of 1 year period, the scotoma, central scotoma, enlarge a little bit. So if they leave the eye untreated, the disease will worsen. So this is the study of the publication of phase 3 trial, and we had this trial. We designed this trial in retinitis pigmentosa patients, and nearly half of the patients experienced visual acuity improvement, and 40% of them remain stable, and some of them worsened during the follow-up period. And this is, as you see, retinitis pigmentosa patient, and this is the visual field of the patient. And after the treatment, you can see the enlargement of the best seeing area, the improvement in the visual field. And this is the multifocal ERG of the patient. These colored eyes, colored areas are the functioning areas. And as you see that after the treatment, the colored areas increase in size. And we had some experience about comparing some different methods. We compared suprachoroidal method with subtenance injection. And I revised the technique a little bit, and I created a second flap under the first scleral flap. And as you see, you can see the choroid color clearly. And we compared this technique with subtenance injection technique, and we reported that as the sclera gets thinner, the results get better. So we are now using this modified technique, and we are dissecting the sclera a little bit more. This is a doctor, a female doctor. She had pseudo tumor cerebri and a secondary optic atrophy. She received bilateral optic nerve sheath fenestration, and she lost vision in her right eye. As you see, light eye has only light perception, and the visual field is totally black. And she had a small area in the left eye, and she can see 0.4 Snellen lines from this area. This area is working and functioning, and she's trying to do her job. And we decided to do stem cell implantation to the left eye because right eye would not benefit from the therapy. And this is the follow-up visual fields of the doctor, and her vision improved from 0.4 to 0.7, and her visual field improved significantly. As you see here, the good areas are enlarged very well. And this is her web test, visual evoked potential test. The right eye was flapped. As you see, the lines are flat. And this is treated eye. This is before the treatment, and this is after the treatment. As you see, there is an increase in the amplitudes of P100 line. This means that we can receive some responses from this eye. This is another patient with optic atrophy. She had head trauma, and after the trauma, she received vision loss, and her left eye had no light perception, and her right eye was like this. Her vision was 0.05 Snellen lines, and she had a small visual field area here, functioning area. And she received stem cell treatment. At the end of the first year, this is the visual field. As you see, there is a good enlargement in the seeing area, in the functioning area of visual field. And she was very happy with that result. This is the web test of this patient. This is the left eye. The results, the lines are flat, as you see. There was no response to the light. And this is the right eye. And the web test improved a little bit after the therapy. Now we have two types of mesenchymal stem cells available in our laboratory. We can use mesenchymal stem cells in suspension. This is called two-dimensional stem cells. It is easy to apply, and it is easy to produce, and the cost is low with this type of mesenchymal stem cells. And the other type is Sepharate stem cells. This is called three-dimensional 3D stem cells. And the stem cells has had long-lasting activity in the tissue, but production is a little bit complicated and the cost is high in this type of tissue. And this is an example for Sepharate mesenchymal stem cells. As you see, this is like a sphere. This had small mesenchymal stem cell bubbles in it, and it is surrounded by a polyethylene glycol matrix, and this causes a slow degradation, and then the activity, the efficacy is longer than two-dimensional one. Now this is the present, and we can do these applications in clinic now, but in the future I believe that 3D bioprinting will be more available and will be more important in the future. As you know, the engineers, the scientists now can bioprint the cornea in 6 minutes, and they are now available for human trials. And I believe that in the future, we will have a bioprinted retina in the market. So nowadays you can use bioprinted retina in some ocular research, because in the laboratory you can produce retinal organoids. The organoids are nearly similar tissue like the eye. So in the future, I think that there will be a device for stem cell delivery. So you can use this device and you will have a long-lasting activity of stem cells. So take-home messages, I can say that there are no guidelines yet for stem cell implantations, because this is very new, and we don't know which cell is more effective, we don't know which cell to use, we don't know which way to use, because there is, as I mentioned before, there are a lot of ways of stem cell implantation, and we don't know which patient will benefit it well. So we have a lot of work to do. But I know that from my experience, suprachoroidal implantation way is safe and effective, and you can use this way in also in children. We are using this technique in children now, with the approval of the government, of course, because we have some regulations in our country. For every patient, we have to apply to the government, to Ministry of Health, and we have to take an approval for the implantation. So there's a lot of paperwork in this application. Our clinical data shows beneficial effects of stem cell therapy in some degenerative retinal and optic nerve diseases. So in the future, I think there will be other kind of stem cell applications, and these applications will increase visual acuity in patients and increase the quality of life in patients. Of course, I am not working alone. I have a great team here. I am working with 2 laboratories. One of them is Acıbadem Lab Cell, and the other one is Genkök. These laboratories both have GMP guidelines, and we are working with a great team here. I want to thank to that team members, and I will finish with the words of Stephen Hawking. So I think that today's science fiction is often tomorrow's science fact. So tomorrow will show other stem cell application types in the future. So thank you for your attention. Thank you for your invitation again.
Dr. Öner, thank you for your amazing talk. Very, very interesting. And as you said, it is, we are living, I think, a new horizon in medicine with this all this wide field of stem cells application in medicine. So
Yes.
thanks a lot. Now I have some a question.
Okay.
After doing and after having such a large and important experience in your group, finally, what kind of source of stem cells do you prefer to use? Umbilical cord or any other adult source of mesenchymal stem cells?
Okay. In our country, we have got 4 main sources for stem cell therapies: adipose tissue, bone marrow, umbilical cord, and dental pulp. I used in adipose tissue-derived mesenchymal stem cells in phase 1 and phase 2. And then we switched to umbilical cord-derived mesenchymal stem cells in phase 3, because our head of the laboratory said that the umbilical cord derived cells have more potential to secrete neurotrophic growth factors. So we switched to umbilical cord tissue, and from that moment we used just only umbilical cord derived mesenchymal stem cells. I had a study, I designed a study for application of dental pulp stem cells, but I couldn't achieve to find a financial source, so it is waiting. But I am curious about the results of that source, so maybe in the future I will have a chance to try it. But nowadays we are using just only umbilical cord tissue.
Okay, thank you. And the option of obtaining spheroids with the matrix of polyethylene glycol, are you also clinically using it more frequent than a stem cell in suspension?
Okay. Actually, we are using suspension frequently, but we encourage the patients to, it depends on the money actually, because the cost of the Sepharate stem cells are a little bit higher than the other ones. So if the patient has a financial source for the cost, we advise to use Sepharate stem cells, because the efficacy of Sepharate stem cells are a little bit longer than the other one. It depends on the budget of the patient.
Okay, but the bottom line is that if the patient can afford it, it will be better to use the spheroids.
That's right.
Because the results will be probably much better.
Yeah,
yes?
That's right. That's
okay,
right.
Interesting. And finally, are you using the suprachoroidal injection with the modification of the deeper dissection of the sclera?
Yeah. After that study, I always do the modified technique, because the results were better in that technique. As the sclera gets thinner, as you dissect the sclera more, the results get more successful. So now I'm using the modified technique. I published it, but if the sclera is thin, for example, in a high myopic patient, I don't insist on dissecting the sclera more.
Okay. And do you ever combine this alternative of suprachoroidal injection with, for instance, intravenous application or not?
Okay. There is a publication from China. They used intravenous injections, and in Scott's group, they are using intravenous injections. For intravenous injection, you need how can I say, 100, no.
A large amount of cells, or?
You need more cells, so the cost is getting higher. You can combine it, but it will cost the patient more money.
I see. And maybe the results are not that different?
The results, I do not have any experience about this combination, but the literature says that the results will be better.
Okay, I see. Anyone in the audience has a question for Dr. Honor?
Yeah, I have one. Hi,
Dr. Rangel, go ahead, please.
Hi, doctor. Congratulations for the talk.
Hi.
I have a question.
Okay.
Is the clinical response in patients with retinosis pigmentaria influenced by the genotype? Or there is no difference between genotypes in these patients?
Yeah, that's a good question. You know that retinitis pigmentosa has different kind of genetic mutations. They have, as far as we know, 270 mutations have been found in RP. We studied the autosomal dominant, autosomal recessive, and X-recessive patients, and we compared them. The results were least successful, better in autosomal dominants and autosomal recessives, but they were the success rate is lower in X-recessive patients. For example, which gene? RPRGR gene. It's the worst one in worst genetic mutation. So if you have a X-recessive patient, you can say that you will benefit less from this treatment. And if you have an autosomal dominant or autosomal recessive gene, you can say that this patient will benefit better from the treatment.
Thank you.
Thank you. Thank you, Dr. Honor. And maybe I'm going to speak in Spanish. Si alguien en la audiencia quiere hacer alguna pregunta en español y la traducimos o intentamos traducirla para hacérsela a la doctora Honor, puede hacerla y nosotros la traducimos. I am telling everyone that
Alejo, quiero decir.
Okay, a colleague is going to make a question in Spanish and we will translate it for you. Adelante, doctor Pedro Luis.
Ok, quería hacerle una pregunta a la doctora Honor, agradeciéndole por esta charla tan interesante. Quería saber específicamente qué resultados ha tenido o si tiene experiencia en neuropatía óptica de Leber.
He says that thank you for your very interesting talk, and what is your experience with Leber optic neuropathy?
Okay, that's another good question. Thank you. We had 3 patients with Leber optic neuropathy, and the results were pretty good because stem cells have a potential to transfer the mitochondria. You know that Leber is a mitochondrial disease, so stem cells may transfer mitochondria to the optic nerve cells. So the results are expected to be good. We have 3 patients. While I'm saying that we had good results, I mean we had visual acuity improvement, we had visual field improvement, but you cannot treat the patient totally. This is not a cure. This is just a therapy.
Yes, and maybe in the future, those patients will need another injection in the future, maybe.
Yeah, that's right. You will need repeated injections in nearly all of the patients, but the injection time will vary between patients. For example, in optic nerve patients, I do the surgery and then I inject the second injection in 6 months. And then during the follow-up, if the patient needs injections, I will repeat it. I injected 3 times in some patients, 4 times in some patients. So you will need repeated injections in optic neuropathy patients, actually, especially because they are the least successful ones. And in AMD patients, we will not need repeated injections, but in RP patients, we will need repeated injections in the future during the follow-up period, because you cannot cure the disease. You will give nutritional support to the patient, and these stem cells will die in the future, and you will need extra injections for the patient.
Perfect. In leber optic neuropathy, do the patients improve in the size of the scotoma or in lines of visual acuity, or both?
Oh, both. You will have improvement in both of them, but some patients had improvement in visual field, but they cannot have improvement in visual acuity. I cannot understand which patient will respond in which way.
Okay, so the results are rather variable.
Yeah.
But some improvement in any of these parameters will occur. So it's a hope. Okay, we have the last question from Dr. Espinosa, a glaucomatologist. He's asking about the optic nerve atrophy due to glaucoma. Do you have experience with such cases?
Yeah, thank you for the question. We retrospectively studied the glaucoma patients. We had this type of treatment in 12 patients, and we are going to publish it. And glaucoma patients respond well to this therapy. In optic nerve diseases, glaucoma is the best. The others are worse than glaucoma, but you need to be sure that the patient is receiving anti-glaucomatous therapy, because this therapy will not end the medication. So the patient needs to use their medication. So you have to be sure that the intraocular pressure is within normal limits. So under these conditions, you can do the therapy, and this therapy will help the optic nerve to survive a little bit, and you can receive visual acuity improvements. You can receive visual field improvements in glaucomatous patients. And there are some studies, clinical studies published in this area, and we will publish our results in the future. We are working on it, and you can do this therapy in glaucomatous patients too.
Okay, and additional questions. In patients which are totally blind, NPL, is there any hope?
With this therapy, no, I can say no. I have some experiences with blind patients. For example, methyl alcohol intoxication, they are blind totally. Or I have a trauma patient with totally blind in 2 eyes. I couldn't receive any response from the retina or from optic nerve, so I'm not doing it.
Okay, and Dr. Honor, thank you again. Very, it was amazing talk, and
thank
will
you.
open us a new field, and maybe we have several patients interested on this therapy. We indeed, here we have a cell therapy laboratory also, but we are just beginning. So maybe we can, in the future, with your help, maybe do something of some of these therapies here in Colombia. We have also a very complex regulation, but we also we can try. But by the moment, I think the first step will be I forgot the word in English, or to send you patients, patients. So we contact you about specific cases of patients that who are interested on this kind of therapies and to go to Turkey?
Okay, thank you. It was a great pleasure for me. It was an honor for me to be with you. Thank you for the invitation. And anything you want, that I can help. Maybe I can do whatever you want in the
Dr.
future.
Honor, thank you very much again, and have a very, very nice evening for you.
Okay, thank you.
Bye-bye, and thank you again.